Hello, namaste. I'm Dr. Basu from Nepal.
Welcome, sir. Welcome.
Hi, thank you. Thank you for the invitation.
Good evening, sir. Good evening.
Good evening.
Good evening, Dr. Basudev.
Yes, good evening. How are you?
I'm good, sir.
Today we are occupied here with Dasera actually. Today is the second last day of the puja actually.
Yeah.
So 7:30 p.m. Good time to start. Over to you, Dr. Ankur.
Sure.
Hello, good evening everyone and greetings from India. A very happy Puja, Durga Puja and Dashera. Greetings from all the members of Indian Society of Anesthesiologists. We welcome you again to yet another SAARC, Association of Anesthesiologists Continuous Professional Development Program and World Anesthesia Day celebrations. To begin, we have our World Anesthesia Day on 16th October, as we all know. So the celebrations have become a lot of programs on the way. And so as today, we have a couple of good, very recognized speakers on platform today. May I now invite Dr. Venkatagiri KM sir. He is a senior consultant in United Medical Center and Carewell Hospital, Kasargod. Current president of SAARC, Association of Anesthesiologists, and past president ISA and past president OMAG. He is the past president and secretary of ISA Kasargod and ISA Kerala. Professional Wellbeing Committee member of WFSA 2016 to 2024. Past Joint Secretary and Vice President IMA Kerala. Past President and Secretary IMA Kasargod. He has attended more than 1,100 state, zonal, national and international conferences and chaired and gave talks in many conferences. It's our pleasure to welcome Venkatagiri sir for today's webinar. Welcome you, sir.
Thank you. Good evening, everybody. First of all, wish you all happy Dasara, and we are on the 9th day, 8th, 9th, in between 8th and 9th, because today is Navami also, 8th day Navami. That's why I told the 9th day. Night is the 9th, Navami 9th. So, Ayudha Puja, Mahanavami and all, tomorrow, day after. That we wish you all a prosperous new year. And also, this we are nearing the World Anesthesia Day. We have combined this with the World Anesthesia Day. We have with us Vice President Anjali, Secretary Dr. Naveen. Our past President, Madam, is there from the beginning only. She is there in this meeting. Then we have from Pakistan, we have people from Bangladesh,
Nepal, Afghanistan.
Basu from Nepal, then Dusuma from Maldives, then Afghanistan we have, and our GC member Dr. Indrani, and from Sri Lanka, Dr. Lankara Samar, and our past president Dr. Mahesh Sinha, Nishant, all are attending today's meeting. We welcome you all for this meeting, and this is a special meeting because it is at the end of our puja time and also just before the World Anesthesia Day celebration. This program conducted every month on the last Saturday. In between, because of practical reasons, we could not make one meeting. That's why we are having it today, that meeting which was postponed last. And two speakers from two countries, member countries are taking. Today we have two talks on medication safety and challenges in low resource setting by Dr. Ashad from Maldives, and opioid-free anesthesia from Dr. Naila from Pakistan. They will elaborate on these topics, and enlighten our members, SAARC members and others on these two important issues. And simultaneously, I don't want to prolong much. For practical reason, we could not have this program at 6 o'clock. We are having at 7:30. Please bear with us for this change of time, though a little late, but we will have a good scientific program after this World Anesthesia Day Felicitation program. Thank you all. Thank you very much.
Thank you so much, sir. May I now invite Dr. Anjali Bhure, Professor and Head NKP Salve Institute of Medical Sciences and Research Centers, Nagpur. She has multiple national and international publications under her credit. She is the current Vice President of ISA National, Governing Council member of ISA National from 2016 to 19, Honorary Secretary West Zone of ISA 2009 to 2015, President of INC NCB 2009, Advisory Board member of MSCICA, Organizing Chairman 2021 ISACON Nagpur. She has received multiple awards at the state, the national level, and she is a very well-known figure amongst all the anesthesiologists. We welcome you, madam.
Thank you, Uncle. Good evening, friends. I bring greetings from India and a warm welcome to each one of you. I shall take you through the journey of various events which are part of this webinar. Honorable President Dr. Venkat Giri KM Sir, Honorary Secretary Dr. Naveen Malhotra, Honorary Treasurer Dr. Virendra Sharma, esteemed executive members of SAARC AA, all the respected presidents, secretaries, and executive members of various associations of anesthesiologists of respective countries of SAARC, Association of Anesthesiologists, our distinguished speakers, chairpersons, senior teachers, senior dignitaries, and dear all attendees. India is in festive mood and is celebrating Navaratri, today being the 9th and the last day. May the divine blessings of Goddess Durga enrich your life with happiness and joy. We all have gathered on virtual platform to have a great learning experience. First of all, I would like to offer our wishes for Happy World Anesthesia Day, as we are going to celebrate World Anesthesia Day, which is celebrated to commemorate the anniversary of revolutionary change that happened in the history of medicine. That is, first time demonstration of anesthesia on 16th October 1846. SAARC, Association of Anesthesiologists, will be celebrating World Anesthesia Day with felicitation of our esteemed members. Medical safety challenges in low resource setting is a critical issue, impacting the quality of healthcare and patient outcomes. Shortage of essential supplies, equipment, trained healthcare workers leads to compromised infection control, medication safety, and overall quality care. Addressing these challenges require innovative solutions, sustainable investments, and a focus on strengthening local healthcare system to ensure safe, equitable, and effective care in these underserved environments. Dr. Dusam A. Raza, President of Maldives Association of Anesthesiologists, will be chairing the first session, and deliberation will be by Dr. Asad Shahid from Maldives, and the deliberation will be on medication safety challenges in low resource setting, followed by a question-answer session. The next session will be chaired by Professor Jadat Salih and Professor Naila Asad from Pakistan. She will be delivering her talk on opioid-free anesthesia, an emerging approach aimed at minimizing the use of opioids in surgical procedures. With growing awareness of opioid-related side effects and addiction risk, this method focuses on alternative techniques for pain management, improving patient recovery, and reducing complications. So let's learn the insights to its potential to enhance the patient care and safety in various medical settings. At the closing, Thanksgiving will be done by Dr. Virendra Sharma, our dynamic treasurer. We are fortunate to have Dr. Ankur Khandelwal, and Dr. Neha Sinha as our coordinators for today's continuous professional development program. Thank you very much. Over to coordinators for further proceedings.
Thank you, Dr. Anjali Bure, Madam, for brief overlay. And it's a pleasure to welcome you all, the esteemed office bearers of SAARC AA, for this CPDP and World Anesthesia Day celebrations. As we are on the eve of World Anesthesia Day, we have fixed these programs for Fridays because it's a holiday in our neighboring countries, Pakistan, Maldives, and Bangladesh. It's a pleasure to invite past SAARC President, Madam Basumati Dimekar ji, to please bless us on the eve of World Anesthesia Day. Madam Dimekar, past President SAARC AA.
Good evening, everyone, my friends and the fellow SAARC members. It takes me back to 1993 when we had the first conference at Dhaka. And I'm very happy to be here and honored to be present today. And I hope all of you will enjoy this seminar, and good wishes to everyone. Thank you, Dr. Malhotra.
Thank you, Madam, for your blessings. And as my previous speakers have told, we are in festive mood and we are celebrating Anesthesia Week in India by ISA, as well as Durga Ashtami, Ram Navami, and the Shera. Now it's a pleasure to invite Madam Vinodini from Sri Lanka. She is the president of College of Anesthesiologists and Critical Care Anesthesia, Sri Lanka. Madam Vinodini, if you can please express and convey greetings on the eve of World Anesthesia Day. And as the theme of this year's session is workforce well-being, so the activities done by the College of Anesthesiologists, Sri Lanka. Madam Vinodini, please.
Good evening, everyone. Greetings from Sri Lanka. So as we approach the World Anesthesia Day, the highlight of the theme this year is the workforce well-being. So which is also a very, very important factor these days with the global crisis in various aspects. And in Sri Lanka, we also have planned an array of activities to celebrate, starting throughout the day on the 16th of October, and in fact throughout the month. So I hope the rest of the countries also will follow the same pathway, and I bring all our best wishes from Sri Lanka to all SAARC countries and to have a very fruitful and progressive year in pertaining to the development and the delivery of anesthesia and also critical care in the respective countries. Thank you very much for the opportunity to speak. And I'll hand over to the Dr. Malhotra.
Thank you, Madam, for your kind words. It's a pleasure to invite Professor Hamid, the General Secretary of Pakistan Society of Anesthesiologists. Sir, please, you are welcome to express yourself. And can I have the slide also for the sir? Dr. Hamid, sir. Please unmute yourself, sir. Sir, you have to unmute yourself. Neha, can we have his slide?
All right. So good evening, everyone. My name is Dr. Muhammad Hamid. I am General Secretary of Pakistan Society of Anesthesiologists Center. On behalf of Pakistan Society of Anesthesiologists, I would like to congratulate the whole SAARC community on this World Anesthesia Day. It is actually a very nice gesture by Dr. Naveen and the President SAARC Association to involve all the regional countries in this celebration. In Pakistan, usually we celebrate under the banner of Pakistan Society of Anesthesiologists this World Anesthesia Day, and it usually held these celebrations held in major cities like Karachi, Multan, Peshawar, Lahore, and Rawalpindi. For example, this year in Karachi, we are celebrating at a hotel on 16th October, and the program includes CME program on anesthesia workforce well-being, and then we will have a cake cutting ceremony on the World Anesthesia Day. This year also is a unique in the sense that PSA has created a task force for the resident well-being as well. So this task force is responsible for taking care of residents, and this is also an opportunity for the residents to discuss their issues with the senior anesthesia faculty. So not only we are celebrating this World Anesthesia Day, and which include also the social gathering. These celebrations also had at different institutes, but also in different cities as well. So this is one of the poster you can see. This World Anesthesia Day values Karachi, and there is a presentation by Dr. Fawzia Ali Khan. So this is on workforce well-being, and residents are also part of the world anesthesia workforce. So we are taking care of those residents as well. So in the end, I will thank you again, the Secretary and President, for giving me this opportunity. So happy World Anesthesia Day. Thank you.
Thank you, Dr. Hamid sir, and it's a pleasure to know about the activities done by Pakistan Society of Anesthesiologists. Now it's a pleasure to invite dear Dr. Basudev Parajali to speak on behalf of SAN, Society of Anesthesiologists, Nepal.
Namaste and good evening, everyone. First and foremost, I'd like to thank SAARC AA President and General Secretary of SAARC AA, and I also like to thank all the representatives of different countries. Thank you for providing me this opportunity to highlight the programs of Society of Anesthesiologists of Nepal. Every year we used to celebrate World Anesthesia Day by conducting various programs. This year we have planned to have blood donation program at my institute at Triveni University Teaching Hospital, where we expect around 50 blood donors, and in the evening we have gathering at one banquet where we'll be celebrating different programs, like we distribute gold medal to the immediately passing out resident who have secured highest mark among across the country, followed by we distribute Sun Research Grant Award to the residents and the faculty, 4 residents and 2 faculties. Similarly, we also have featured talk on the theme, mainly related with the theme, that is strengthening our foundation, cultivating workforce well-being in anesthesia. The talk is being delivered by one of the anesthesiologists. He is one of the senior anesthesiologists in the private hospital. Followed by we have annual general meeting for our which includes only the life members. It will be around 30 minutes. Beside that, we have recently formed Society of Anesthesiologists of Nepal anesthesia related consent form, which we are going to endorse from the AGM itself, and we'll be highlighting the talks related with this theme in the upcoming conferences. Conference which will be held in 2025 April. We'll be planning accordingly as well. Yes, so these are all activities of SAN. I cannot share my window, my screen over here. I'll just share the slide, and maybe Dr. Naveen can help me to share that. Okay, I'll just share in the group over here.
Co-host, sir, you can share now. Your co-host, please go ahead.
Yeah, so yeah, that's all from my society. Thank you.
If you want to share the screen, most welcome.
No, like I'm using my mobile actually.
Okay,
So
okay, fine,
yeah,
fine.
I'll just send you because of the festival. I'm sorry for this.
No issues. I know we are all in a festive mood, and it's pleasure to invite now the president of Maldives Association of Anesthesiologists, Dr. Dusuma Abdul Razak. Madam, please unmute yourself, madam.
Good evening, esteemed SAARC executive members. Wish you all a happy World Anesthesia Day. And the activities planned by anesthesiologists of Maldives will be briefed by our secretary, Dr. Zulaiha Mai. Dr. Mai.
Oh, yes. Good evening, everyone. I'm Dr. Zulaiha Mai, so I'm just here to. Hello, Dr. Zulaiha Mai. I hope you all can hear me.
Yeah, madam, loud and clear. Please go ahead.
Just congratulations and a very happy Dashain to everyone who's celebrating from Maldives and all over the world. And I'm here to brief you about the small activities that we have planned for the Anesthesia Day, which will be celebrated on 16th of November. Actually, from Maldives, we are doing a series of events. Initially, we started with a pre-workshop on pain management for inpatients and like to start a pain clinic here. So we have conducted that on 9th of this month, 9th and 10th, a 2-day workshop has been completed. And then we are celebrating further on the day itself, opening with a small ceremony on behalf of the function, how the anesthesia day started and all, and like also, we have opened up a poster competition because the theme for this year was workforce well-being. So we have opened up a poster competition for the hospital, and those who are interested have been like posting us with different sorts of posters to make people aware of how the workforce well balanced to balance this actually. So we have offered many prizes and all those things to be given after selecting one of the best posters, and this poster will be shared in most parts of the hospital so that people can go through and to spread awareness of workforce well-being. Other than that, we also have a dinner night, which will be planned for most of the anesthesiologists from different hospitals as well. Will be welcomed, and then the day will be ended with the function itself at hospital levels. That's all from all these.
Thank you, madam. And I've got galaxy of speakers lined up. Dr. Shanta Snavtata from Nepal, Dr. Jempel from Bhutan, and then I'll invite Dr. Mahesh Sinha from India. Madam Shanta, please.
Thank you, Dr. Naveen. Good evening, and everybody, all of us are in the mood of festive. Still, we are together. It's nice to, and we are celebrating another great festival, that is World Anesthesia Day. That's another great event for us. As Basu has already informed, detailed in about the sun. Myself, I'm out of capital, and I'm in my remote place for festival. And I'll say again, happy World Anesthesia Day and happy Dasara and Diwali. Thank you.
Thank you, madam. So, Dr. Jempel from Bhutan.
Unmute कर भन्दा चाहिँ वास्तै नगरेको त
Yeah, please go ahead.
Thank you very much for organizing this one. We in Bhutan has actually nothing much special to celebrate and plan in plan, but we are planning in a small way to have a small lecture and a cake cutting ceremony, maybe for 1 hour. That's what we are planning on 16th of October. Otherwise, Bhutan being a very small country, country and a very small community is a big challenge for us. And in the country, we are maybe around 15 of us. Virtually, we have a society, yes, but officially, no, because our society is not yet recognized by the government. Because in Bhutan, none of the societies are recognized yet. We are not allowed to form any association or society. So it's a big challenge for us to organize all this. So that's all I can say. But by the way, let me wish all of my dear colleagues, and especially Hindu community, a very happy Durga Puja and a very happy World Anesthesia Day. Let's wish for our well-being of our own colleagues for years to come. Thank you very much.
Thank you, Dr. Jempe. Now, Dr. Akbari is representing Afghanistan Society of Anesthesiologists. If you or any of your colleagues are there from Afghanistan Society of Anesthesiologists or BSA CCPP, please unmute yourself. And by the time you do so, I request Dr. Mahesh Sinha, past Vice President of ISA, to express himself. And I can see Dr. Indrani Hemant Kumar also, our Governing Council member, ISA National, to convey greetings for the World Anesthesia Day to the SAARC delegates. Please unmute yourself. And as we all know that the theme of this year's World Anesthesia Day is workforce well-being, and numerous activities are done across the country in India by our parent body, Indian Society of Anesthesiologists, for the well-being of the anesthesiologist, whether it is academic, clinic, research, and member welfare activities. So we are 5 minutes away from starting our scientific program. If anybody of you is interested to express, he or she is most welcome. Please unmute yourself, and if you want to convey greetings or felicitations, you are most welcome. I can see Dr. Pramod Bhalle sir also, and Dr. Chauba Singh. Anybody of you is most welcome. And then we will start our scientific session. Dr. Virendra Sharma, you can also express yourself and convey greetings. I know you'll be called for vote of thanks also, but on the eve of World Anesthesia Day.
Thank you, Naveen. Actually, I was thinking that when I'll give the vote of thanks, I'll convey the wishes.
Okay. So this year, the theme is workforce well-being, and we have to ensure that the physical, mental, spiritual well-being of all the colleagues is maintained, and we all have to work towards that end. Dr. Indrani Hemant Kumar, please.
Thank you very much, sir. And I take this opportunity to wish all of you a very, very happy Dasera and Durga Puja, and a happy World Anesthesia Day to all of you. So I think it's time to reflect on what our forefathers had given us from the days of ether. We have come all the way to an automotive anesthesia. So again, a day to reflect on what the steps we have taken to come this far. And again, a lot of things to do from, in future too. So thank you all very much for giving me this opportunity. Thank you, sir.
Thank you, madam. So another 2 minutes left. So anybody from Sri Lanka or Bangladesh, Nepal?
Dr. Naveen, can you just share the screen? Actually, I have sent you in WhatsApp or in the group as well.
Okay, I'll ask Ankur to do the honors. Ankur, I'm sharing you a flyer. If you can just project it, because I'm also it's in my mobile phone. In the meantime, I can invite Dr. Abraham to say a few words, or anybody else is most welcome. Ankur, if you can share the flyer which I have shared with you on WhatsApp from Nepal, Society of Anesthesiologists, Nepal. I will be really thankful to you.
Sir, I have not received it yet.
Yeah,
Once I receive it, I'll share it.
it now you have sent it.
Yes, sir.
Dr. Abdul sir, please, you can express yourself. Please unmute yourself and you're most welcome. And Dr. Baletar, you're co-host now and you can, so this is about the SAN. Okay, over to you, Dr. Basudev.
Yes, so as I said, like our features talk by Dr. Apur. Yes, the topic is over there, and the different programs to have the annual general meeting as well. So yeah, I just like to share our activities. Thank you. Yeah.
Thank you, Ankur, for helping us out. And with this, I think time has come to move to the scientific.
Naveen sir.
Yeah,
Naveen
please.
sir.
Yeah, please, sir. Over to you, sir. Yeah.
At outset, I want to thank you to say me few words. Happy World Anesthesia Day to all of our colleagues, seniors, and all, and happy Dashera also. Thank you, sir.
Thank you very much, sir. And greetings to all. Is reiterated on the occasion of Durga Ashtami, Navratri, and Dashera. A few words from Dr. Sarma P. Abraham, please. Madam, unmute yourself.
Sarma Abraham. Sarma
Yeah,
Abraham.
Dr. Abraham is there. And Madam, unmute if you unmute yourself. Unmute, Madam. And we have got Scientific Secretary of ISACON 2024, Dr. Nishant from AIMS Patna. So you can invite all to the ISACON Patna. Nishant.
Yes, sir. Thank you so much. And yes, a very warm welcome to everyone for the ISACON at Patna, ISACON 2024. And this will be held from the 20th to the 24th of November this year. And we would love to have all the SAARC nations, dignitaries from the SAARC nation to be there. And a very warm welcome. It is a place of a lot of traditional significance. We have, it is the birthplace of at least 3 religions. So there are a lot of places to visit in and around Patna also. A very warm welcome to everyone from the 20th to the 24th of November this year. Thank you, sir.
Thank you, Dr. Nishant. So I can see Dr. Chandrakant Patel, Dr. Choba Singh, and Dr. Mayank. Anybody of you, Dr. Leena Patil, anybody wants to express, Dr. Mahesh Sinha, most welcome. And from other SAARC countries, we have got another 1 minute left. So I'll request Ankur to please start with the scientific proceedings. Thank you all for the part 1 of today's webinar for the combined first ever online celebrations of World Anesthesia Day. And we are very thankful to all our participants from Nepal, Bhutan, Pakistan, Sri Lanka, Afghanistan, and Maldives, and of course, India. Over to you, Ankur.
Bangladesh doctor has sent a message in WhatsApp, Dr.
Yeah, they have sent a message.
That unable to attend due to
geopolitical conditions.
program and some problem with their geopolitical reasons. He is not able to. So anyway, we thank them also for giving this message during this period.
So almost so all the countries have been represented, and it's pleasure. So Dr. Giri, we move on to the scientific session now.
Please, we'll move on.
Right. Over to you, Dr. Ankur and Dr. Neha.
Thank you so much, sir. After this introduction to webinar by Professor Anjali Bhure and a grand round of felicitation and coming to know about stalwarts from different countries and senior representatives, it's now the time to move on to scientific sessions. It's my first webinar as a coordinator for SAARC AA. Kindly forgive me if I make any mistakes. I had two options today, to either to go to puja and visit all the pandals or to sit and be a part of this webinar. I opted for the second one. I am very delighted for it. Our first talk for the evening is medication safety, challenges in low resource settings. To chair the session, we have with us Dr. Dusuma Abdul Razak. She is a Chief Surgical Officer and Senior Consultant and Head of the Department of Anesthesia in ADK Hospital, Maldives. She is President of Maldives Anesthesiologist Association, Vice President of Society of Critical Care and Emergency Medicine. She has been the pioneer in conducting cardiac surgeries in Maldives since 2018, initiated labor analgesia services in ADK Hospital 2018. She has a clinical attachment in labor analgesia, North Middlesex University Hospital, London. She is a diving medical officer in Singapore General Hospital and a reviewer in multiple journals. It's a pleasure to have you with us, Madam Dusuma.
Thank you.
As a speaker, we have Dr. Asad Sahid. He is a consultant anesthesiologist in Maldives. He has special interest in pain medicine, regional anesthesia, point of care ultrasound, cardiac anesthesia, and airway management. We also welcome you, Dr. Asad Said sir. And now I request you to kindly begin your presentations and enlighten us with your talk. Thank you so much. Dr. Shahid, you can share your screen.
Shahid.
Yes,
Dr.
sir.
Shahid,
You can
just
share.
start your video so that I can make you co-host.
Yes, please.
Okay, now you are a co-host and you can share the screen.
Thank you, Dr. Navin. Good evening, everybody. I hope you can see the screen and you can hear me clearly.
You're visible, but your screen is not there, sir.
Screen is not visible, sir.
How about now?
Yes, sir. It's now visible.
Yeah. Thank you so much. Thank you, Dr. Navin. Thank you, Dr.
But I'm just interrupting you again. Can you make it a slideshow?
Give me a moment.
Yeah.
Is it okay?
Perfect.
Yeah. Sorry about that. Okay. Thank you, Dr. Navin. Thank you, all the presidents and all the participants of SAARC Anesthesia associations and everybody who's participating from their respective countries. And a very happy World Anesthesia Day for the upcoming World Anesthesia Day, and a very happy Dashan to everybody who is celebrating. So on this webinar, I wanted to talk a little bit about a very practical issue that we face on a daily basis from a country that is very small, the smallest country in the region and the smallest, and with a very unique set of geographical peculiarities. So let's just go with the topic. So I wanted to start with a case, a very small case that we had very recently. It's a 38-year-old male who was posted for a right ACL reconstruction, and then anesthesiologist has advised for 1 milligram midazolam, and instead he received 5 milligrams of midazolam, and he was delivered by the anesthetist nurse, and he was monitored for the rest of the surgery. He became drowsy and he required oxygen, but no further events occurred to discharge and no further interventions were required. So this is just what I want to talk about, and then let's just see what are the challenges that we face with regard to such issues and why do we have those things and what can be done as a community of anesthesiologists here that we can try to solve one of these things. So we conduct about 4,000 cases in this hospital in IGMH, which is basically the final referral hospital in Maldives. It's a small hospital compared to probably everybody else who is conducting cases. But these are data from the last 2 years, 2023 as well as 2024, what we the operation theater basically events incident note, and for the 2024. Again, the blue one in the middle is what is for the medication errors. And only 5 cases were recorded in the medication errors so far in 2024, which is the last one here, wrong dose administration of midazolam. What was advised was 1 milligram and instead got 5 milligrams is the one I just mentioned. So first thing, about medication errors, when you look at the literature, there's about 5%, 1 in 20 cases are known to be of some importance, which definitely means for us it's underreported. And there's very limited studies in our context, especially in low middle income and upper middle income countries, that focuses on such things. And nationally, we do not have any published data on what happens in our hospital or other hospitals in Maldives or even nearby countries as such much. So there's this very nice article that focuses on evaluation of perioperative medication errors and adverse events. So they were able to notice about 44.8, which means about 45% of some event happening in their 277 cases. So what they have done for this study is basically kept an anesthesiologist or perioperative nurse and just observed what happens during the surgery. And they defined a medication error as well as an adverse drug reaction. And on the pie chart on the side, it shows how much of it happens and what is considered what. Which means that we do not record a lot of near misses in our context. We do not have, I think, the resources to do that. If we start doing that, probably everything will probably be recorded as a near miss. So they recorded 207 anesthesia, up to about 3,600 medication were administered during those things, and a medication error or adverse drug reaction occurred in 48% of those things. So the same articles, they tell you about what kind of errors they were able to notice. So labeling errors, I imagine if we start recording labeling errors, it probably is going to fill the whole page. Wrong dose of administration, omitted medications, document errors, and monitoring errors. Wrong medication, wrong timing, inadvertent boluses as such. And so this all came down to about 48% of the cases they have recorded. This was a study from Nepal, actually, where they have reported on critical incidents during anesthesia and early postoperative period. And they were able to record about 1% that is related to drugs. 2 were about wrong drugs and drug overdose and inadequate effect of non-polarizing muscle relaxants, inadequate effect of reversal agents. And having been in Nepal and having practiced in Maldives as well, I'm sure this is as well as an underreporting, which they actually acknowledge in the discussion as well. So this prospective observational study from Madagascar, this was basically a European team who conducted cases in Madagascar. They were able to notice about 4% of the errors. So 4% of the errors related to medication in their studies of patients. Which is about what seems to be right for about 4 or 5% of the cases. So The first challenge that we have to overcome is the lack of data, I think, limited reporting and fear of punitive actions. We need to build a safety culture to improve this reporting. Punitive actions deter reporting, and this encourages a culture of secrecy, and we do not know what's happening, and a lot of near misses as such are missed. So medication errors reported were less than what's reported elsewhere. So that was, I think, the first challenge as a group that we need to be talking about. So when it comes to medication safety, there's a lot of talk about it. WHO basically launched it at the third Global Patient Safety Challenge back in 2017, and the World Patient Safety Day was celebrated 2022, 2 years back on the same topic. So they highlight key priorities: high-risk situations, polypharmacy, transition of care, which is where we come in, and look-alike and sound-alike medications. These 4 high-priority areas were where a lot of medication safety errors occur. As we know, our patients are getting older, they're getting bigger, they're getting on more drugs at a given time, and they come from wards, they're on medications. We sometimes don't know what's going to happen with them. And so perioperative care becomes a big area, especially that this is quite a significant issue. So, and the other problem about anesthesiology per se practice is that we do the prescribing, dispensing, administration, monitoring. The whole thing is done by us together. So it's very difficult to see our own faults. That becomes a problem with reporting as well, as you can imagine. So the medication safety can happen during procuring, it can happen during storing, as well as dispensing of medications. And human factors like fatigue, poor work environment, and staff shortage are major reasons that errors happen. Human factors cannot be brought down to zero altogether, but we can try to bring it down as much as possible. The reporting systems need to be more vigilant to catch all of these things. And the other problem is in these resource limited settings like ours and yours, probably everybody's overworked. There's a lot of fatigue. There's a lot of burnout that's happening, and that contributes to all of these things happening more and more frequently compared to what's reported elsewhere in the West. We can classify these errors into different things when it happens, the stage of the process, the causative factors, the mechanism of error, and clinical impact. This is quite important, the last point, whether it caused any harm or not, whether it is potential to harm or not. And either way, we are supposed to report it, but we rarely go to anything that doesn't cause much effect. So this is from the previous study that I quoted before. So the labeling errors were about as such. So where does Maldives come? So that's all about what medication error is. So Maldives is about 500,000 people. We spend about 10% of our GDP on this, on health, which means we're probably a lot of sick people. We are in this region, and then we are considered to be in upper middle income countries, which is quite misleading in the sense that people think we are rich, but we do not have any resources to go with it. So that's what I want to talk about, what resource limitation in our context means as well. So 10%, quite a significant amount of money we spend on healthcare, and still we are quite sick. So this article from BMJ Global Health, they talk a little bit about what it means to be resource limited. And they talk about something quite significant about the terms that your first world versus third world, what old world means. And this one in the middle, high income countries versus low income, middle income countries, low middle income countries. So this is the current one that World Bank uses. The methodology is quite clear. It's quite better than the West versus the East and things like that, but it's a small percentage of the world population who live in low middle income countries, but and then their resources are also quite less compared to the other countries. And the article talks about why these nomenclature is problematic, and it tells you a new way to think about what resource limited is actually. So low resource versus resource limited does not necessarily equal to low middle income countries. So for example, like Maldives, we consider that World Bank considers us to be upper middle income countries, but we do not have any natural resources. We do not have medical colleges. We do not produce any drugs. So which brings us to, in this context, quite resource limited. So that's the point I wanted to highlight in this article. So what they say is specific on why and how for low resource is quite important, rather than just consider everybody to be lower middle income countries or upper middle income countries. So in terms of financial terms, knowledge, infrastructure, human resources, physical infrastructure, service delivery, and even geography in our context is quite challenging, because we are a very small island that is dispersed over a very large area. And the historical underpinnings of such resources are quite important to call somebody a resource limited, and in what context. And also, resource limited can shift depending on the issues under discussion. And as you can imagine, even in the same country, there could be multiple pockets that has different kinds of resources available to them, which is quite significant when we talk about the larger countries in our region. So Maldives, I would say we are resource limited, even though as per income, that is gross national income, we are considered to be upper middle income. We are non-manufacturing country. We do not have our own resources. We have limited healthcare personnel. We do not have a very well-developed healthcare education system. Our first batch of MBBS students just recently passed. No residency programs just yet. So access to publications and literature is quite limited, and we do not have much published data on the nation itself. So in that regard, I'll continue. Just to one point, this is from the UN 2019. It just puts South Asia where we are. We're just above Africa in terms of GDP, and we have a lot to catch up, which means as a whole region, we have quite a lot of limitations that we need to be talking about. So the challenge too, I would say, is to understand its resource limitations and resources that are situation specific and are key to understand the limitations of a given region or a country. So in this current scenario, the drug that was given was not produced by it. The concentrations are not set by it. We just take it out. We have to dilute on our own, and we give as such. Because if you look at the literature, they're said to give the preloaded syringes and things, and those things are not available in our current settings. And when we have to procure these things, we need a little bit of shelf life as well, and things like that has to be considered. The third thing I want to talk about is human resources, of course. So human error, we are talking about human error. All these medical errors are technically avoidable circumstances, a lot of them, if not all of them. We have a scarcity of anesthesiologists, as you can imagine, and till currently, I think we are working 9 anesthesiologists from Maldives, and the rest of the people working here are filled by expats. We have a lot of Nepalis, a lot of Pakistanis and Arabs and Indians who are currently filling the gaps we have, which means they work here for a very short duration of time, and they do not have the time to adjust to the local context and understand what's going to happen with it. So, and the other thing is training and educational resources are quite limited because we do not have residency programs, and disparity in training and skills are very variable because we train abroad and from different countries with different sets of skills and different sets of resources. And as you know, anesthesiology has its own limitation about acknowledgement and remuneration disparities with compared to, let's just say, our surgical colleagues. So those things just kind of puts a limitation as to who we can recruit into anesthesia to have any interest for medical officers and things like that as well. So there are a lot of challenges to why we do not have anesthesiologists currently as needed. So which is, I think, a big challenge for us. So human errors are basically mistakes that can be, as I said, classified into different things: knowledge-based errors, rule-based errors, action-based errors, and memory lapses and things like that, which can all technically be corrected in terms if we can do that. This is just for knowledge sake. WFSA recommends there to be 5 anesthesiologists per 100,000 people. Right now, Southeast Asia, Sierra region has about 2.5, I think. So which means there's a lot of gap to catch for this. Just for our individual countries, I think for South Asia, it's about 1.2. That PAP is physician and anesthesiologist personnel per 100,000. So we have a lot to catch, and this all adds up to our limitations in terms of medication error. So the challenge 3 is to understand that human factors leading to medication errors, lack of adequately trained physicians and nurses is a major concern. Access to data knowledge and up-to-date knowledge, overwork, burnout contribute to increased medication error. So the staff who administered this medication and the staff who ordered the medication were both expat doctors who were working here for a very short time, and they probably had different drug concentration or different vials and different pills that they work together. So those add up to them making a mistake as such. And the third thing is we had to know about his medication management systems. So we currently, a big portion of this has to concentrate on selection, the purchase, the storage of medication. And the other problem we have with the purchase, especially procurement, is mostly in the small country. It is no drug company is willing to make a very small batch of very particular drugs just for us. So the one we want is quite difficult to get sometimes, and we have to change from company to company and just at some just settle for whatever is available. And the other thing is to train all the staff, because as I said, the turnover is quite high for our staff, so that training is quite limited, and access to literature and legislation for medication is quite limited, as you can imagine. And we currently are working on institutional SOPs, but we are never there as such. So this was a recent work that was done over here. So NABH, we try to get NABH accreditation, and they have this requirement in terms of management of medication, and a huge part goes to them. So as I said, production is beyond our control. Medication is imported from various regions around the world. We have, by law, Maldivian Food and Drug Administration is legally responsible to create the essential drug list and approved drug list. There is an essential drug list, but which none of them are usually available. Not a lot of them are usually available, even though they are considered essential. So that's a limitation of the system, even though we have by law that these drugs should be available in different parts of the country, they are not. So the issue comes from related to drug procurement and as such. So the recommendation to have medicine management systems and stock review, supply, expiry date checks, and access to appropriately trained pharmacy staff to manage. Even though it's recommended by the rest of the world, it's quite a difficult thing for us to practically manage at times. Even now, we do not have a proper software facility, even in the operation theater, to do that. I believe some of the hospitals, other than IGMH, does have it. We do not have an in-house pharmacologist either to manage these things. So there comes another limitation of the system. So even though in hospital pharmacies and OR storage are recommended, we currently do not practice it. We currently do not have it. We just have a staff who manage, a nursing staff who manages those things for us. So this is an article about from India. Actually, they did this was from by a survey they sent for 4 hospitals from I think Mumbai, that they had sent a questionnaire, and they found out if those essential medications, this is not related to perioperatic care, but essential medication availability, so factors affecting the availability and utilization of essential medications. And they found that there was a huge disparity in the availability of essential medications. So you can see that only in some situations, only less than 40% of the places had essential medication. So this is something, a major challenge all of us, not just perioperatic care, has to handle. And the other thing is, Maldives, the healthcare system is quite diverse, in the sense IGMH is one of the hospital, and we have very small hospital. This I found from a regional hospital. I asked them what are the drugs that they currently procure for their operation theater, and they gave me this huge list. Some of them are definitely not being used by them, and because of that, probably they are not getting what is required, and they do not have some of this. They definitely even do not have naloxone there. So, and as for procurement and just drug manufacturing, I just wanted to point out, when the issue occurred, these were the medications that was in the controlled cupboard. As you can see on the leftmost, the midazolam, ephedrine, the pethidine, and then also they all look so similar, but we do not have the luxury of choosing one brand or the other, and we just have to choose. And we also do the opposite on the right side. The same medication comes in different packaging, which also sometimes could be very problematic for us to recognize that. And storage, I think the nurses might not like me showing this picture, but this is how it is. The reality of the situation is the labeling, as you can see, is not appropriate. The drugs are usually mixed up, bundled up together. On the left is a mixture of a lot of drugs that we currently have. And this is something we have to be focusing a little lot more on, I guess. So storage and preparations are very individual dependent as well. And currently we do not have a uniform protocol of doing these things. This is the picture from the control medications. Even naloxone is kept there. This is usually very well managed by the nurses because they have their ways to do it. They have at least 2 points of nurses have to give consent for the drug to be taken from there. But I think just by looking at it, we all can recognize that a lot can be improved on that front. Yeah. So this is from the Royal College of Anaesthetists from UK. So they give these recommendations. So immediate access should be there for some essential drugs and emergency drugs, depending on the situations. They do not recommend what are the essential drugs as such, and local SOPs is a must, and balance approach between patient safety, staff protection, and security. Example, in terms of whether to keep a medication locked or not, and things like that has to be context dependent. And they also ask the anesthetic room to be visible all times and cupboards to be locked whenever possible, and to make an emergency drugs to prepare them accordingly. And they are okay with the rarely used medications to be elsewhere in a centralized location. Just to point out, we do not have dentrolene. I don't think we have had it. Just we are hoping that nothing like that happens to it. And intralipid, it just comes and goes from stock all the time. Access to control system, and just making that only few people who are privileged to go there should be able to go there. So these are the 10 recommendations that our COA gives about it. And this is from WHO, just a general pamphlet about during the medication safety project. They had this. So our fourth and main one is medication management system should be context specific, essential drug lists, uniform procurement procedures with a focus on packaging, proper storage and dispensing systems are needed. Special focus should be given to high-risk medications used in limited settings, and emergency drugs perhaps. Packaging and labels on it were beyond our control, of course, but we can do a lot more, perhaps, for example, about proper labeling on our syringes, just assigning whether to use different sizes of syringes for different purposes or not. And just to point it out, in case we had to use a reversal agent for that midazolam, we do not have the antidote either here available in Maldives. So I just wanted to, these are the 4 challenges that I wanted to talk about. And in terms of that simple case, what could have gone wrong, and then what could have been done to prevent in terms of our local resource limited context. So just a few things that we can do on our own to make sure that we give the correct medication, correct dose at the correct time. Just handle one medication at a time. Quarantine medications, preparation activities to a different area. Check every while, make somebody read it out, maybe the expiry date, the preparation, the dose, the concentrations, perhaps. And all syringes should be labeled with standard color-coded labels. If medications are injected into an IV bag for infusion, it must be labeled properly as well. Keep a standard order and syringe sizing for each medication. That just helps prevent any mixing. Do not drop medication until they are needed. Relaxants should always be separate. And then we try to have, this comes from New Zealand and Australia, I think, to use red syringes. And I understand it must be quite difficult for us to procure it. Never reuse a red label syringe for anything other than muscle relaxants. And medication for emergencies given via route that is not IV or that would be harmful outside that specific purpose has to be kept away from other medications. All IV medications must be, access points should be flushed before they're coming out. And just all medication, the adverse events must be reported via an incident reporting system. So if we stick to these 12 points diligently, we can try to reduce all the medication errors that we have, hopefully. These are some of the resources that I looked into, and the others are with the slides there. Yeah, thank you very much.
Thank you, Dr. Shahid, for these excellent presentations. It is indeed very challenging to conduct safe anesthesia in resource-limited settings and yet perform evidence-based medicine. You have highlighted all the important constraints that can take place in a resource limited settings, as well as highlighted those key points that needs to be taken care of or can be preventive in reducing the errors. We are now open up to the discussion. May I now invite Dr. Dusuma Madam, if you can share your viewpoints on this important topic.
Good evening, Dr. Asad. A very excellent presentation. And this topic aligns closely with this year's World Anesthesia Day theme too. Like, despite we follow all these points of safety, we still have like human errors can occur. Plus, there are chances of medication error if the workforce well-being is not there. So workforce well-being is essential for ensuring medication safety. And I think maybe other members can highlight other important points regarding this presentation.
The topic is open for discussion. If you have any queries, kindly unmute and please put your queries.
Ankuram, I must congratulate Dr. Asad for nicely elaborating this topic, and the punch was the golden rules which he has said in the last few slides. Heartiest congratulations, Dr. Asad Saeed, and I'm very sure he has made it so simple and lucid. I don't think there is any space for the queries, but still they are most welcome. Heartiest congratulations.
Thank you, sir.
And I can tell you that he was preoccupied, but Madam Dusuma agreed to honor the commitment and also to the change timings. So I thank both the speaker, Dr. Asad and Dr. Dusuma, for this presentation on behalf of Maldives Anesthesiologists Association. And there is one comment that can you please send your references? Okay, that's fine, from Dr. Ramya. Okay, so how will he send it now?
I will try to share it where you. I'll send them. I'll send the presentation.
In the meantime, you can put it in the chat box, the references. Okay.
Yeah. Thank you.
Ankur, over to you for the next session. Thank you, team Maldives Anesthesiologists Association.
Thank you, sir, for this opportunity.
Thank you, madam, and thank you, sir. And I echo the words of Professor Malhotra, sir, that the presentation was so simple and lucid that it hardly puts any option for putting queries for the speaker. We now move on to our very next important topic. Again, very important matter of very hot discussion across the different countries, which is opioid free anesthesia, sometimes referred as opioid sparing anesthesia, opioid restricted anesthesia. So many terminologies have been defined in the recent 5 years or so. And to discuss this topic, we have with Professor Naila Asad from Pakistan. But before that, it is my pleasure to introduce to our chairperson for this talk, Professor Judaat Salim. He is a professor in anesthesia and intensive care unit at Postgraduate Medical Institute, Amiruddin Medical College, Lahore General Hospital. He is president of Pakistan Society of Anesthesiologists, Lahore chapter. He is a member faculty of CPSP and a member executive board, University of Health Sciences. We welcome you, Professor Salim, for this webinar. To discuss this talk, we have Professor Naila Asad, Head of the Department of Anesthesia, Services, Institute of Medical Sciences, Lahore, Pakistan. She is a member of MS Anesthesia Committee, University of Health Sciences, Lahore, Pakistan, Advisor Synopsis Review Committee, Member Inspection Team for Organ Transplant, Teaching Faculty Diploma Managerial Course in Cadaveric Transplantation, Member Department of Medical Education, Service Institute of Medical Sciences, Lahore, Member Institutional Review Board, Member and Supervisor of Anesthesia in College of Physicians and Surgeons, Pakistan, Examiner and Paper Setter for various universities, Vice President of Society of Anesthesiologists of Pakistan, Lahore, editorial panel in various journals and reviewer again in various journals. We welcome you, madam, and now it's my pleasure to kindly ask you to begin the presentation.
Madam, your audio is not coming.
Can you hear me now? Hello.
Yeah, now you're loud and clear. Can we go to the first slide, please, ma'am?
Yeah. Yes, the first slide, this was the first slide. I'm talking about thanking the organizers for inviting me to this talk on opioid-free anesthesia. Thank you so much. And this is a very hot topic, which is now it's globally all over the world about opioid-free anesthesia. Now, everybody knows in the medieval times, opium had been used as part of sleep-inducing sponges like Spongia spongifera, and for pain control during the surgical procedures. Now, then this was shifted to with the upcoming of chloroform in 1847, though opium was, these sponges was shifted to chloroform. And then in 1960s, the advent of this halothane, isoflurane, the inhalational agents, they came up, and this was in this. And then in 1930s, we came up with the IV thiopentone sodium, which is the IV induction agent. Now, coming up to the opioid-free general anesthesia, as everybody knows, it's a new paradigm. And the opioid-based anesthesia, that was the turning point in the balanced anesthesia, which we called, with the development of synthetic opioids in 1960s. And why do we need to know about these opioids is because the effects are they block the autonomic nervous system, they maintain the intraoperative analgesia with hemodynamic stability, they provide postoperative analgesia. And but we have some hazardous effects for which we get very upset as an anesthesiologist. The first thing that patient goes in respiratory depression, for which we avoid these. There is pharyngeal muscle weakness, post-op nausea, vomiting, urinary retention, constipation, pruritus, tolerance, hyperalgesia, and which could progress into chronic pain syndrome. And the worst of all is opioid dependence. So as everybody knows, the saint is a sinner too. Since 1999, the opioid overdose deaths had occurred, and they had quadrupled since then. And half of these had been because of prescription drug, and most people, they used it as painkillers from friends and relatives. And on an average, 91 Americans die each day from an opioid overdose. Now, what do we need to know for this opioid crisis and opioid epidemic is that I can tell you about these three ways which tell us that the overdose deaths, they started in 1990s. As you can see this graph, and that arises from then in 2010. Since then, the rise in heroin that caused the overdose and the deaths occurred. And from 2013 till 2021, you can see the rise in synthetic opioid overdose, which goes up till here. And this is the deaths per 100,000. So here the graph is risen so much. Now, there is a paradigm shift towards this, that a combination of various opioid-sparing techniques, which leads to no administration of intraoperative systemic neuraxial or intracavitary opioids. This is now coming up. But why do we need this? Why do we need to move towards this paradigm shift is that we need to fight the opioid crisis. We need to avoid the side effects. We need to decrease the intraoperative, postoperative opioid requirements, and enhance the fast-track recovery, to enhance the quality of recovery, post-operative analgesia, to reduce the length of stay in PACU, and to minimize the post-operative cognitive dysfunction. So you can see so many factors which can be avoided by using an opioid-based technique. And in this, we use the multimodal analgesia with anesthesia with these opioid-free drugs, which are gabapentenes, NMDA receptors, lignocaine, loco-regional anesthesia, anti-inflammatory drugs, alpha-2 agonists. So what's the challenge which we have to face in this opioid-based anesthesia, opioid-free anesthesia, is that we need to devise the regimens. We need to optimize the drug selection. That has to be very adequate and optimized. And then we need optimal doses for intraoperative and immediate post-op analgesia. And we need improved recovery. The benefits of opioid-free anesthesia are patient-related as well. Certain population like obesity, patients with obstructive sleep apnea, cancer surgery, colorectal surgery, and with chronic pain syndromes, they benefit from this opioid-free anesthesia. And the best of all is that you can avoid the opioid addiction. Now, this was a study by Muhammad Ibrahim et al., and they concluded that opioid-free anesthesia enhanced the total quality of recovery scores and the individual scores of its 5 dimensions at 6 hours when compared to multimodal analgesia, and they used the validated QOR40 questionnaire. And this was done in laparoscopic surgery. Effect of opiate, another one which was done by Bello et al. They did it on effect of opioid-free anesthesia on post-operative epidural ropivacaine requirement after thoracic surgery. And they found that opioid-free anesthesia might reduce the consumption of ropivacaine, early post-op pain scores, requirement of morphine titration after thoracotomy. Then the latest is in using a combination of ketamine and dexmedetomidine in laparoscopic cholecystectomies. And this Vishnu Raj KR et al., they did this, and they had 2 groups in which one they gave fentanyl was used in opioid group. The other group was given bolus of ketamine plus dexmedetomidine. And they found that patients required, the requirement of analgesia was reduced in the first 2 hours post-operatively, and there was decreased post-op nausea vomiting. Now you can see the post-op fentanyl requirement in time to first rescue analgesia is considerably reduced in the first 2 hours, which is significant, though it is reduced afterwards also, but it's not significant. The pain scores, they are also reduced pain scores are seen significantly at 2 hours, and but there is no significant difference after that. Another study in a gynecological laparoscopic surgery, the quality of recovery was seen after opioid-free analgesia. And this was by Choi H. et al. And they found that the duration in PACU was significantly less in opioid-free group when it was compared with remifentanil. And the dose was also lesser. In remifentanil, they gave 0.11 microgram per kg per minute. The time to extubation, there was no significant difference. And in the visual analog scale scores, after 30 minutes, they were significantly less in opioid-free anesthesia group when compared with remifentanil. But there were no significant difference was seen after 24 hours. The rescue analgesia was also in less number of patients, 21.6% as compared to 73.7% after 30 minutes. And also it was less in 73% versus 81% in remifentanil group. Now, another study which was done in mastectomies, this was that patients, one group was received erector spinae block with opioid-free analgesic mixture of dexmedetomidine, ketamine, and magnesium sulfate. And the other group was given normal saline with the rectus spinae block. Now you can see how the VAS scores were in group M. It was significantly less at 2 hours. Till 2 hours, the VAS scores were less in the opioid-free anesthesia group when compared to the normal group. And the analgesic requirement was less. And the first time for rescue analgesia was increased significantly. The patient satisfaction, 54.5% patients were very much satisfied with the opioid-free anesthesia when compared to the normal saline group, which was 15.2%. Another study was done in breast cancer pain scores and immune response with opioid-free anesthesia. In this, thoracic paravertebral was given with 0.25% levobupivacaine and along with the atracure and general anesthesia. The other group, which was given 0.1 milligram per kg nalbuphine as incremental doses. And this is, as you can see here, that with opioid-free anesthesia, you can see the vascos during arm movement were, here you can see they were less than this opioid-based anesthesia. And during rest as well, there is a significant difference among the two. The tumor necrosis factor, there was a significant decrease in the tumor necrosis factor from the basal 24 hours and 7 days post-operatively in both the groups. And the interleukin 10, that was higher significantly in opioid-free anesthesia when compared to opioid-based anesthesia even after 7 days. The neuropathic pain was also assessed by DN4 questionnaire, and that showed lower scores in opioid-free anesthesia, which was with significance. Another thing which was seen in these was the post-op nausea vomiting. There was a significant decrease in post-op nausea vomiting in opioid-free anesthesia. Then coming to the patient degree of satisfaction, there was significant difference. The patients were very satisfied with opioid-free anesthesia. Another study which looked at the enhanced recovery for after surgery pathway for minimal invasive lumbar spine surgery, they showed that total perioperative consumption was greater in opioid anesthesia group as compared to opioid-free anesthesia group. But in PACU, they did not see a significant difference in the opioid, but intraoperatively they did find it, but not in the PACU. It was there was not significant difference among the two groups. So you can have varying scoring systems, and the NRS scores were also not significantly different among the two groups in PACU as well as initial. So various we can see the differences in different studies. And this study was done with dexmedetomidine versus balanced anesthesia with remifentanil for a non-cardiac surgery. And then this, the Balel et al., they also found that the opioid-free balanced anesthesia with dexmedetomidine resulted in greater incidence of post-op adverse events as compared to balanced anesthesia with remifentanil in patients undergoing elective, intermediate, or major non-cardiac surgery. Now, what they found was that there was a hypotension in dexmedetomidine group, 97 people versus 94. Bradycardia was in 30 versus 14. So there was more of this, and the duration was not significant. It was significantly less in remifentanil, the mean duration of stay. So then, so there are different results. Different studies have shown different results. And another con is that the concept of pure opioid-free is, because the con to it is it's without sufficient evidence to become a routine practice. Propofol, ketamine, benzodiazepines, and gabapentin, they have also, it has been shown that substantial addictive potentials. And the literature, there is little data, no high quality evidence is collected that switching from a multimodal regimen to opioid-free anesthesia offers any benefit to the patient, which would justify that these often complicated and expensive regimens. So, well, in conclusion, I would say that this is a safe and effective opioid-free anesthesia is a safe and effective approach which might change our practices in the years to come. It hasn't yet, but it might. But we need more evidence and focus studies in specific surgeries and patient populations for it to be established. So, and the choice of adjuvants which can be used in this, they need to be documented, that whether they should be procedure specific, they should be patient specific. Also, we need development of intra-op nociceptive monitoring as well. So that's all. Thank you.
Thank you, ma'am, for this excellent presentation. Again, discussing on the very important and hot topic. May I now invite our chairperson, sir, to kindly open up the discussion.
Yes.
Professor Salim, your viewpoints on the topic.
I think Professor Salim is there.
Naveen sir.
Any suggestions can also be very
No,
welcome.
Thank you, madam.
Yes.
It was, see, this is the topic which has drawn attention throughout the world and
Yes.
also in India and SAARC region also to go for strategies for opioid-free anesthesia and analgesia. And you rightly and nicely covered. Just to recapitulate and what the message, madam, you like to give it to the residents on the eve of World Anesthesia Day, because they look upon us, the teachers, okay, we won't use opioids, and wherever possible, we will go for regional anesthesia. But at all, if we have to go for opioid-free anesthesia, and starting from pre-medication, maybe a simple laparotomy comes up and upper abdominal surgery, just a scenario, general anesthesia. And what will be your advice to go for pre-medication, any drugs to be given in the pre-medication, and then the other drugs to be given intraoperatively, and what we can do strategies for post-op analgesia.
Well,
advice to the residents.
Yeah. For residents, for a laparotomy case, if we are doing a laparotomy for pre-medication intro, we can always go nowadays. The ultrasound loco-regional anesthesia is very much in. So we are going for, usually I myself also, I use the blocks for the post-op as well as intra-op analgesia. I give them before the anesthesia. We can put the patient to sleep, and before the surgery starts, we can always give them the loco-regional anesthesia that can be used for all these things, along with paracetamol. And along with the, you can add for anxiolytic, as an anxiolytic, we can always add Domicum, midazolam, short acting. And nowadays, dexmedetomidine is, I think, it is used most commonly, I think, being the drug which is sometimes it's a one, because it provides you anxiolysis, it provides you sedation, it provides you pain-free. So we can, with appropriate dosages, if you know the accurate dose, we can use that accurate dose, and we can work with that as well. And along with the loco-regional anesthesia, I think that is the best thing to avoid the opioids and their adverse effects. And
Thank
the
you,
house is open to discussion.
There is one.
This is my.
There is one query in the chat box. Has any of the authors in any of the studies looked at the incidence of awareness on opioid-free anesthesia?
No, I think that needs to be, the authors did not check into the awareness because for awareness, I think we can use the inhalational agent for that purpose. We can use that. So we never use it below their MAC value, definitely. If we are using opioid-free anesthesia, we need to use the MAC value as well, as I said. So if you are keeping the accurate MAC in the inhalational agents, I doubt if you get, I have not experienced the awareness except in the section patients, cesarean sections. Yes, they are a challenge for us. But in that, if the challenge is that after the baby comes out, you can always use dexmedetomidine in them as well. I think that can be used in the accuracy of dose. Optimal dose is the word I should use, which does not cause its hypotension, which does not cause bradycardia. So that is, I think dexmedetomidine is a wonder drug which is used. I think you must be using it a lot as well, because we are using it a lot.
Thank you, ma'am. Thank you for responding to that query. If any delegate is having any other query, kindly unmute and please put your query.
I have a question.
Yes, sir.
Yeah, opioids are supposed to provide some kind of protection against ischemic heart disease patient. So you think that opioid-free anesthesia would be a good choice for patient with ischemic heart disease?
I think it is a good choice for definitely we give it in cardiac patients. We do use opioids because it's the best. I think it's the best choice in cardiac. You can we can't. I don't think so. We can have any other thing except I don't have the experience of using anything else in cardiac patients. So I personally think, yes, you are right in that sense. Yeah, but the studies can be done. You know, that's what the last conclusion slide was, my concluding slide was that there are a lot of things which needs to be explored in this topic, because there is like one question is awareness has to be explored, and this can only be done by studies, by research work. So we can do research work on patients with CABG using other drugs which are available. And I think we can then only, and a number of evidence, which should be evidence-based studies, can only answer that question. Not my single person cannot answer. I can't answer that and say categorically, yes, cardiac patients should not have it. Because, you know, there is a pro and con debates that is still this is still going on debates. It's not, but it is globally being very promoted. I hope I've answered your question. If you have a comment, I'm ready to have it.
Ma'am, there is another one query in the chat box. Isobaric 0.5% bupivacaine comes with methylparabine, which is the preservative. Is it safe to use this in epidural? Your expert opinion.
Methylparabine.
That is the preservative in 0.5% bupivacaine
5%. This is by Harvard.
Tell me one thing.
Yeah, I think
Okay.
methylparabine.
I'm
Sorry?
getting to know people here. Okay.
Isobaric 0.5% bupivacaine is, I think, used everywhere. And if it is coming with the methylparabine, I think we are using it in spinal anesthesia. We're using it in epidural anesthesia. And this is preservative free. It is, sorry? Preservative free is available. So we are using isobaric 0.5% bupivacaine, preservative free. I don't know if the Harvard ones, which the Harvard company that makes it. So with methylparabine, we don't use that. Because in epidural, even in blocks as well, I prefer using preservative-free drug. Like we have lignocaine with bupivacaine, rupivacaine, and then you can add an adjuvant to it, dexamethasone, preservative-free. So even in peripheral nerve blocks, I prefer using preservative-free. So I think preservative-free should be used.
Thank you,
Yes, nowadays all the preparations are available.
Yes.
Preservative-free and which are used definitely hyperbaric. We have been using it, which is preservative-free for the spinal anesthesia, the hyperbaric which we are using. And now whether it is isobaric 0.5%, 0.25%, or the levobupivacaine, and they are all available as preservative-free preparations.
Yeah, all of them. Now I think they don't have preservative in them, as you said.
Ma'am, is there any preservative-free methylprednisolone which can be recommended for epidural steroid injections?
No, we use dexamethasone, decadron, and
See, Dr. Jampi has rightly
methylprednisolone.
said that this is out of context topic, but yes, we pain physicians are using day in and day out steroids for epidural steroid injection, and each and every only thing which is available right now, which is recommended, which can be used safely legally, is dexamethasone. Now, if
Dexamethasone,
you
yeah.
use triamcinolone or if you use methylprednisolone, they are off-label use, and each and every manufacturer says they are not meant for epidural injections. But yes, there are numerous thousands and thousands of literature available where they say that you can use in the lumbar route, you can use epidural steroid injections with the
methylprednisolone. We use dexamethasone.
or triamcinolone. Yeah. There are thousands and thousands of in PubMed index CTRI studies. So, but this is a totally
different topic.
The use of particulate steroids in epidural steroid injection.
Ma'am, next.
Sorry, it is completely out of topic, but I was in little dilemma because we had been using triamcinolone. The only preservative-free triamcinolone is not. It's difficult to get in the open market, but even if we get in the open market, it is a particulate. So particulate one, we are a little worried about end arteries in the spinal cord, and we are looking for alternative drug, and the only thing that I thought of was methylprednisolone, which is supposed to be preservative free. But then we are not able to get the preparation that one also. So now as you suggest, thank you very much. I think we should go for dexamethasone.
Dr. Jampel, thing is methylprednisolone is also a particulate steroid. And in chronic pain circles, there has been a long-term debate about use of particulate versus non-particulate steroid. And the current recommendations are that if you want to use for epidural steroid injections in the lumbar route, if you wish, if you want, you can use particulate steroid. Definitely, you're going to inject under image guidance, and that too fluoroscopic guidance, where you're going to put a radio contrast dye, and you are almost ruling out intravascular uptake. As far as anything above nipples is concerned, and if you're going to do for cervical epidural and other things, then it is a big no. You have to go for only dexamethasone. But there are many pain physicians who use dexamethasone in all the routes of epidural injections, but there are many who still use the methylprednisolone, which is also available right now, and also the different preparations of triamcinolone. If you ask me personally, I've been using both methylprednisolone and triamcinolone for decades together for the lumbar route. And for the cervical route, I use only dexamethasone.
Thank you very much, sir. For us, we usually use for the lumbar epidural. We never go up beyond thoracic and above. So thank you very much.
Right. Thank you. There are a few comments from Nishant and other. Ankur, if you can take them.
Yeah. One more query, madam.
Yes,
in
sir.
India, opioids are not available over the counter. So reasonably using opioids in India is a safe practice. But question to you, is it the right time to bid adieu to opioids, or still there is time? What is your final take on it? Are we at the right time to say bye-bye to opioids, or we do have time?
No, I think we do have time. As I said, there is still debates which are going on. Opioids are there because of their adverse effects. But like I said, we have to go for further researches first. We have to have evidence, documented evidence, and then we can only go for, we can go say bye-bye to opioids. Not, I'd like we talked about cardiac surgery, like cardiac patients. We do need opioids in them. We have not found another drug which can replace that. We still have to work on it first. We need to. This is not what I should say. Yes, I can't say that by my conclusion, you just read it. I didn't say yes, opioid free, but it is a globally moving on. But they are trying to, when this is going to happen, we can't say. But we need to have those drugs which are better for the cardiac patient. We need to devise some drugs instead of opioids first for cardiac patients, and then only. And that, I think that will take some time after so much of research work on different drugs. Like the one question, awareness. We need to find it out first, whether this opioid-free anesthesia causes awareness or not. We need to find it out, whether it helps in cognitive dysfunction. We need to have documented evidence-based. Only then we can say, yes, now say bye-bye, because we have so much evidence against the opioids. This drug is better. These drugs, rather. I would say there won't be one drug, but we have to go on for different, multiple drugs. We have to use them. And then we can say, we can't just say, at this moment, it's difficult. No, I won't say. That's what my conclusion wasn't targeted towards opioid. It was a generic. We need to work hard. Patient population. We need to see. We need to, because we are working on evidence-based anesthesia. That's how, like, propofol came. First, it was thiopentum. How did propofol come as an induction agent? There was so much work done on it first, and then they launched it. This is the benefit of the propofol. So please bye-bye to thiopentum. Now you can't find thiopentum. So that's how it works. It can't be done in a day or so. It has to be years of work, and then some drug can be launched or some drug can be wiped out. Now you can't find thiopentum. That's it.
Thank you,
So
ma'am.
thank you
Thank
so
you
much.
so
I
much
hope I've answered their question.
Yeah, thank you so much for wonderfully responding to that query. I hope this responds the query of Dr. Nishan Sai and every one of us all. We are not yet ready to bid adieu to opioids. Still there is time.
We have to work hard to say goodbye to them. All of us have to work hard on it.
And meanwhile, during the discussion, a lot of suggestions have stemmed up in the chat box regarding regional techniques, ketamine, dexmedetomidine, and various drugs. I'm thankful to all the delegates for putting your wonderful suggestions into the chat box and being actively participating in the webinar. Thank you, madam. Thank you, sir,
so much
for your active participation. Naveen,
And,
sir,
thank you for having me.
And can we have comments from the chairperson also?
I think chairperson.
Okay. Okay, Ankur, go ahead.
Fine.
Yeah.
Go ahead.
So before we come to the end of this webinar, the mandatory vote of thanks by Dr. Virendra Sharma, sir. Professor Dr. Sharma, sir, if you are there, you can present your vote.
Yeah, he is very much here.
Yes, sir.
Dr. Virendra Sharma, Treasurer of SAARC AA, and over to you, sir.
Thank you, Dr. Ankur.
Thank you, sir.
Good evening, respected President SAARC AA, Dr. Venkatagiri, Dr. Naveen, Secretary, respected office bearers from different countries of SAARC AA. Yes, I do agree that this is the festival season here in India and maybe Nepal and some other places. And ISA is celebrating week-long World Anesthesia Day. So today's program online started at 6. But I appreciate that our SAARC CPDP attendance has been almost constant. So we have our own audience and representatives from different countries. The topics today were really interesting, and that is why so much of discussion did happen. I congratulate both the speakers. And there was some discussion regarding this year's theme of safety, well-being of anesthesiologists. So just for information that we in India, we sort of freelance private practitioners, and in 2017-18, we started programs for them and issued guidelines. Now this year we'll be issuing the revised guidelines. Just to clarify that these guidelines were basically meant for those like limited resource, the first speaker. So what minimum standards should be there where an anesthesiologist should be giving anesthesia. So yes, we are working on that, and I hope that other colleagues in the other countries are also working on the freelance practitioners' point of view. And wishing all the best and a very happy World Anesthesia Day to all of you. Thank you.
Thank you so much, sir, for the vote of thanks and final words from you. Over to you, Naveen Malhotra, sir.
Thank you all for joining today's program, the combined online celebrations of World Anesthesia Day and the SAARC CPTV program. See you soon for the next program. Good night, all. Thank you very much.
Good night, everyone.
Happy Vijay.